The way that I recommend studying antiarrhythmic drugs is by reviewing the action potentials. In fact, if you understand the action potentials and how the drugs affect the action potential, you can predict a lot of the properties of our antiarrhythmics. Here we're looking at a fast response fiber. Let me remind you that these are fibers that are found in the muscle of the heart. So that would be atrial and ventricular muscle, and also in the His-Purkinje system. In these fast response fibers, in phase 0, you get rapid depolarization due to the influx of sodium. So let's focus on the action of the drugs. We have a group of drugs called sodium channel blockers that are important antiarrhythmics. They're going to depress the slope of phase 0 in fast response fibers. So I would encourage you to draw that image, to draw that depression of the slope into your book as you look at this diagram. The second group of drugs that works on this action potential are potassium channel blockers. We know that potassium is important for repolarization in phase 3. So a potassium channel blocker, can you draw that diagram? It's going to prolong repolarization, meaning that it takes longer to return to resting potentials. So sodium channel blockers and potassium channel blockers are the two most important types of antiarrhythmic drugs that work on fast response fibers. Now, can you make this connection? If you think about fast response fibers, where do you find the largest number of these fibers in the heart? Well, it's in the ventricles. The ventricles make up the largest mass of the heart, and therefore they have the most fast response fibers. So here's a connection. Drugs that work on this fast response action potential are going to be very effective for ventricular arrhythmias. If you like to divide arrhythmias into two categories, there are ventricular and supraventricular arrhythmias. Ventricular arrhythmias are treated by drugs that work on fast response fibers, and you know that would be sodium channel blockers or potassium channel blockers. Now let's take that same thought, that if these drugs working on this action potential work in the ventricles, and the drug blocks sodium channels, and I depress phase 0 depolarization in ventricular muscle, what interval on the ECG is going to be prolonged? What's the interval that corresponds to ventricular depolarization? And that's QRS. So sodium channel blockers are going to prolong the QRS interval. On the other hand, what do you expect a potassium channel blocking drug to do to the ECG? By prolonging repolarization, and takes longer to return back to rest, that means you're prolonging ventricular repolarization, which means you're prolonging the QT interval. So notice how much time we spent on that one figure, talking about the action of the drugs, the type of arrhythmia that they can treat, and then the intervals on the ECG that are going to be affected. The next several slides are going to review the different phases of the cardiac action potential in those fast response fibers. I want to do just a few things with the text on each of these slides. In phase 0, where sodium channels are opening and sodium is rushing into the cell, the rate of depolarization depends on the number of sodium channels open. So when we talk about class 1 antiarrhythmic drugs, these are our sodium channel blockers that can slow or block phase 0 in fast response fibers. In phase 1 of the action potential, sodium channels are inactivated. In fact, antiarrhythmic drugs have very little to no significant effect on these transient currents. This is where we're seeing the outward potassium current and an inward chloride current that contribute to this notch in the overshoot in phase 1. Phase 2 is known as the plateau phase. You have a slow influx of calcium, which is balanced by your late appearing outward potassium currents. Importantly, antiarrhythmic drugs have no significant effect on these currents. You'll notice in the previous diagram, we didn't discuss action of drugs on phase 2. Phase 3 is where we see repolarization caused by potassium efflux. This is where our class 3 antiarrhythmic drugs are going to work. All of those class 3 drugs are potassium channel blockers. In phase 4, we return to resting membrane potential. And phase 4 potential is maintained by the activity of sodium-potassium ATPase. We have very few to no drugs that work in phase 4 of the action potential, though we will see one group, one subgroup in fact, that has some actions on phase 4. When you consider responsiveness, that term is really referring to the capacity of a cell to depolarize, and it's associated with the number of sodium channels that are in the ready state. We're going to look in a few moments at another slide. Looks at the different states of the sodium channel. So when you're talking about responsiveness, you're really thinking about how many sodium channels are ready to respond and in that ready state. This depends on the resting membrane potential. In fact, the more negative the resting potential, the faster the response. When it comes to conductance, the rate of spread of an impulse, also known as the conduction velocity, has three major determinants. It would be the rate of phase 0 depolarization, the threshold potential, and the resting potential. Here's our second action potential to look at. This is the one for the slow response fibers. When you think about slow response fibers, you're thinking about the SA and AV node, specialized tissues in the heart. The shape of their action potential is totally different from the one for fast response fibers. In fact, you need to remember that it's calcium that's the key ion for phase 0 depolarization in slow response fibers. So if I ask you to identify a type of drug that's going to be an effective antiarrhythmic and works in slow response fibers, it's pretty obvious that it's calcium channel blockers. They're going to depress the slope of phase 0 in slow response tissues. Notice there's no phase 1 overshoot, there's no phase 2 plateau in slow response tissues, but there is a phase 3 repolarization caused by the efflux of potassium. So potassium channel blockers certainly can prolong repolarization even in slow response fibers. Drugs that are potassium channel blockers, therefore, have utility in a wide variety of arrhythmias because potassium is important in fast response and slow response fibers in order to repolarize. There is a second group of drugs that works on this action potential, and it works very similar to calcium channel blockers. That group of drugs, of course, is beta blockers. Beta blockers can actually work as an indirect calcium channel blocker. You might remember this from a diagram we covered in the previous chapter when we were talking about positive inotropic drugs. Do you remember that beta-1 agonists like dobutamine and dopamine can stimulate beta-1 receptors? You increase cyclic AMP, you activate protein kinase A, you phosphorylate calcium channels, and more calcium comes into cells. So stimulating beta-1s increases the amount of calcium inside cells. Therefore, in the heart, what if I block beta-1 receptors? Well, I get the opposite. By decreasing cyclic AMP and inhibiting protein kinase A, my calcium channels are not going to be phosphorylated, therefore they stay closed. Beta blockers have an indirect calcium channel blocking effect by depressing the slope of phase 0 and even, to some extent, depressing the slope of phase 4. Remember, phase 4, shown on the bottom right of this figure, is the pacemaker current. That's where you get calcium influx, but you also get sodium influx through those funny sodium currents. So beta blockers and calcium channel blockers depress the slope of phase 4 and phase 0. Now, what type of arrhythmia would a drug that works on slow response fibers be useful for? If you're thinking, could it be ventricular or supraventricular? Where do these drugs work? In the SA and AV node, which are found above the ventricles. So calcium channel blockers and beta blockers are useful for SVTs. Because they're working in the upper part of the heart, what interval on the ECG is going to be prolonged? What is that interval that illustrates conduction through the atria? That's the PR interval. So beta blockers, calcium channel blockers, prolong PR. I mentioned the intervals because these are popular descriptors of our drugs, and you might be asked to identify those in a test question. Finally, you can use this picture to discuss what happens when you have increased sympathetic or increased parasympathetic firing to the heart. Remember that the rate is controlled by the firing at the SA node. If I increase sympathetic activity, I'm going to increase the slope of phase 4 and phase 0, so I depolarize even faster. Parasympathetic actions will do the opposite, decreasing the slope of phase 4 and phase 0. So parasympathetic actions, or vagal techniques, are going to have the same type of effect as a calcium channel blocker or a beta blocker, which means vagal techniques are useful for supraventricular tachycardias. As we discussed in the previous slide, when you consider automaticity, this is the ability to spontaneously depolarize. The tissue with the fastest phase 4 slope will determine the pacemaker of the heart. Of course, that's normally the SA node. The SA node sets the pace in the heart because it has the fastest rate of phase 4 spontaneous depolarization. Of course, occasionally you can get an ectopic focus, where some other tissue in the heart is actually setting the pace because of its ability to spontaneously depolarize very rapidly. Next, we want to consider the refractory periods. We have the effective refractory period and the relative refractory period. The effective refractory period is sometimes referred to as the absolute refractory period, where no stimulus of any magnitude can elicit a response. And the reason why you cannot get a response when the cells are in the ERP is because sodium channels are in their inactivated state. They stay in the inactivated state until late stage 3, and that's where we start to see the transition from the effective to the relative refractory period. This also explains why a potassium channel blocker will prolong the effective refractory period. It takes longer for your sodium channels to go from the inactivated state back to the ready state when you prolong repolarization. And we'll discuss more on an upcoming slide about exactly why those sodium channels take longer to reset. In the relative refractory period, a strong stimulus can elicit a response, but the timing could be out of sync with the rest of the heart. The ratio of the ERP, the action potential duration, is a measure of refractoriness of a tissue. Decreases in ERP favor formation and propagation of premature impulses. So certainly you think about, in the relative refractory period, we can get a response. Sometimes that arises out of late phase 3, and sometimes it arises out of phase 4. I've returned to rest, but I get another action potential without the appropriate diastolic interval. Here's a figure that helps us to look at the relationship of the ERP to the action potential duration. In fact, let's discuss this figure by looking at the line that I've drawn into the picture here. That line is representing the action of a drug, and therefore you should recognize that drug as a potassium channel blocker. By prolonging repolarization, it takes longer to return to resting potential. But potassium channel blockers also prolong the action potential duration. It takes longer to repolarize, therefore the action potential is longer. But can you explain why a potassium channel blocker prolongs the ERP? Remember, the ERP and the transition to the relative refractory period happens mid to late phase 3. And it happens because your sodium channels are returning back to the resting state. The opening of your sodium channels is voltage dependent. The signal that resets your sodium channel and returns them back to rest is when the membrane potential gets negative enough. Notice with a potassium channel blocker, it takes longer to reach that negative membrane potential that stimulates those sodium channels to return back to the resting state. So potassium channel blockers not only prolong repolarization, they prolong the APD and the effective refractory period. Here we look at the 3 states of the sodium channel. There's the resting state, the open state, and the inactive state. Notice the resting state. You have a couple of gates here called M gates and H gates. In the resting state, M gates are closed and the H gates are open. Now we call these M and H because that's the shape of the conformation of this ion channel. It looks like the letter M, looks like the letter H. And so in the resting state, sodium cannot enter the cells. The M gates are closed. Our antiarrhythmic drugs have the least affinity for the resting state. To say that a different way, antiarrhythmic drugs don't bother sodium channels in the resting state. The open, also called the active state, happens in phase 0. This is where the M gates flip open and sodium rapidly rushes into the cell. But you all know that phase 0 happens very quickly, so sodium channels don't stay in the open state for very long. With that very steep slope, the time interval is very short for sodium channels to stay in this state. Because what happens very quickly is late in phase 0, those H gates swing closed. This is what we call the inactive or the refractory state, where when the H gates are closed, you cannot get sodium into the cell. The inactive state lasts from late in phase 0 through phase 1, through phase 2, and part of phase 3. Of course, we just finished talking about the transition from the effective to the relative refractory period. During the effective refractory period, 100% of our sodium channels are in the inactive state, which is also referred to as the refractory state. That's the state during the ERP. But as we transition to the relative refractory period, some of our sodium channels return to rest. They go back to the resting state, where the M gate closes and the H gate opens. The signal to return back to the resting state, at approximately -50, the M gate closes. At about -85, the H gate opens. So you have to get to a negative enough membrane potential to reset your sodium channels. Let's think about the drugs. If antiarrhythmic drugs don't bother resting sodium channels, clearly that means they either target open or inactivated sodium channels. And that's true. All of our antiarrhythmic drugs that are sodium channel blockers work on either the open or the inactive state. Which of those two states is a more obvious target? Maybe a different way to say that is, which state lasts longer? Clearly, it's the inactive state. In terms of amount of time, it lasts in that state way longer than it does in the open state. So many of our drugs actually target the inactive state of the sodium channel. And it turns out that that's true not just for antiarrhythmics. That is true for anticonvulsants that block sodium channels as well. You might be thinking of drugs like phenytoin or carbamazepine. They block sodium channels in the inactive state. You might also make a connection to local anesthetics. Local anesthetics are sodium channel blockers. What state of the sodium channel do those drugs block in? It's the inactive state. Because there's a very nice parallel between arrhythmias, seizures, and fibers that conduct pain signals. It turns out that all three of those are examples where you're having rapid firing of nerves, rapid firing of tissues in the heart in the case of antiarrhythmic drugs. The more rapidly those tissues are firing, the better a sodium channel blocker is going to target that specific area, prolong the inactive state of the sodium channel. The rate of recovery of sodium channels are dependent on resting membrane potential. The fastest rate of recovery occurs in normal resting potential, and recovery slows as membrane voltage increases. It's important to note that the rate of recovery is much slower in ischemic tissue because those cells might actually be partly depolarized at rest. It turns out that sodium channel blockers also slow the rate of recovery in such tissues, and specifically, we have a group of antiarrhythmics called Class 1B drugs that target ischemic tissue and go after the sodium channels found in that part of the heart. With regards to autonomic regulation of the heart, nodal tissue, especially the SA node, heavily innervated by both parasympathetic and sympathetic fibers. Parasympathetics go to the M2 receptors, sympathetics to beta 1. So phase 4 slope is increased when you increase cyclic AMP by activating beta 1s, and slowed by a decrease in cyclic AMP resulting from M2 receptor activation. This is the rationale once again behind vagal techniques. To increase parasympathetic firing, you activate M2 receptors, decrease cyclic AMP, and that slows down conduction from the SA down to and through the AV node. To look specifically at what changes in cyclic AMP are going to do, if you increase cyclic AMP, you're going to increase upstroke velocity in pacemakers by increasing your calcium current. With regards to a decrease in cyclic AMP, beta blockers prevent cyclic AMP formation. That's why their primary effect is on the SA and AV node, as we discussed in an earlier figure.